All right. Good afternoon, everyone. Thank you for joining me this Tuesdays for this educational webinar. My name is Olga Kabinska. I have been handling credentialing processes for almost 17 years. As the director of credentialing department, as a consultant, as a specialist for sleep, mental health, and therapy, I often organize these type of webinars to educate about credentialing, to answer questions, to share what I know, to solve problems and challenges that are taking place in the industry today. And every year it gets to be more challenging. Hopefully today I will be able to present some of the solutions for the challenges that our healthcare providers are facing today. Give you a couple key factors, solutions where you can seek help, and also accommodate by answering questions. When we originally scheduled the webinar, we had opened a form for questions, and we actually received 78 questions. Now, I know that everyone needs an attention to the matter, and I need to address each one separately. So instead of doing the questions and answer session on this webinar, I will be personally reaching out to everyone that has joined us and answering the questions and consulting you on the way to get you out of the challenges and get you credentialed as a provider. So we're going to focus today on the challenges in credentialing. One second. So some of the challenges that I see happening today, doesn't matter if you are a physical therapist, a radiologist, freestanding facility, a cardiologist, a primary care physicians. The main challenge today, and this is some of the things that I have received in the emails from the participants in today's calls, is the closed panels. How do we penetrate the panels? How do we get into the network? What do we have to do to get an approval? How do we speak with insurance reps? What's happening? Why am I graduating and I can't get into the panels? What should I do with my practice? Should I sell? Should I go into the hospital umbrella? What should I do? Closed panels is an issue. For some time, many years ago, it was for certain specialties. Now it's affecting a lot of specialties, a lot of states, a lot of different insurances. We will talk about some of the things here today, and I'm also going to be hosting a different webinar for closed panels later on, and we'll send an invitation explaining it. The second challenge is the delay in credentialing process. Some of you have asked, well, how long does credentialing take? Credentialing typically is 2 to 3 months, and you get your doctors approved, your facility credentialed, and you're ready to start billing. But not with everybody today. United Healthcare is behind, Anthem is behind, Medicaid is behind, Medicare is behind. There is a great delay in credentialing process from initial credentialing to demographic updates. There is a delay, it's true. We'll talk about how to avoid some of the delays, what can you do from your side that will expedite the process, and pretty much how to establish your communication with the payers, that your credentialing is done in a timely manner. Another issue that we have is that unavailability of enrollment regulations by many payers. If I'm a physician practicing in New York and I have a physician license in New Jersey and I want to practice in New Jersey, I need to understand the state regulations. Some of the insurances do not provide regulations in credentialing. They ask you to go speak to the attorney, a healthcare attorney that will advise you on this matter. But if you can't start with a healthcare attorney and you want to continue with doing credentialing on your own, you would need to request the contract, you would need to review the regulations, but not all of this is available right away. Insurance companies, not all of them, make it available on their websites. You will have to leave a lot of messages, and hopefully someone will call you back with that answer, which takes time, a lot of patience, and you usually do not get an answer back. Another challenge that's coming up that we see coming from the billing side is the missing parts of the plans after approval. Anthem has about 47 different plans. Anthem is the Blue Cross company. When you apply for credentialing, you pretty much apply for everything that's available. You assume that everything is available and you get approved. Once your credentialing is complete, you receive a nice welcome letter, And then you really have no idea what plans are part of this approval. So you have to investigate, you have to call, you have to check directories. This information is not available until the point of authorization, until the point of claims processing. Then you get a denial that you're not a participating provider with this plan. So it's a big issue, a mispresentation by the insurance companies after the credentialing process. Another issue that providers are coming to us with is the lack of clarity in the enrollment denials. Physicians get denied. I'm sorry, we cannot accept you. Mobile clinics get denied. Urgent care centers get denied. We apologize, we cannot accept you. And there's sometimes not a reason for the denial. We have to contact the provider rep, we have to write a letter asking what is the reason for the denial. So sometimes the process of a denial is also not clear. And we really have to target the insurance company to find out the reason we are being denied. Does it have to do with the sanctions on the doctor's file? Does it have to do with too many locations? Is my doctor on SIU list for investigation? There's a lot of things that come up that are not clear right away during the credentialing process. And for someone who is doing credentialing for the first maybe couple months, it's hard to understand the process. And for someone who's doing credentialing for a long time, they have to really know where to call to get the answer. Another final challenge that's coming up today, it's incorrect credentialings that lead to drop in reimbursement. Oh, the CPT code was not added to your contract. You cannot bill for this. It's out of network. You will not get reimbursed. A lot of issues in credentialing relay in billing, and we see this a lot. Contracts get dropped, plan get drops, we're still billing it. Locations are not added, we're still billing it. So reimbursement is affected directly by the way the credentialing is done. And it's very important that the billing department and the credentialing department work as one family. Understanding the guidelines, sharing the information, informing everyone that there's a new physician, closure of the location, something that's not getting paid because of the specialty issues. There has to be a communication between credentialing and billing department today. In the industry also, there's a shift now where attorneys are picking up the business for credentialing. Physicians are going now to lawyers and asking them to help to get them into closed panel, asking them to write an appeal letter to prove the medical necessity, asking lawyers to help them to get contracted. And this is the shift that's happening already for the past couple of years. And attorneys, there's a lot more now qualified healthcare attorneys that are handling these tasks. We have consulted many, so attorneys are now also taking part in the credentialing process for the doctors and for the facilities. What's on our agenda today? We're going to cover several key points. We're going to talk about credentialing maintenance that affects every single provider, facility provider, any type of Part B outpatient building facility or practice. This affects credentialing maintenance. We all know how to get contracted and what we do with the contract that we have. How do we maintain it? And it's very, very important. We'll talk about non-renewal of provider contracts. If you are today a participating United Healthcare provider, you might be at risk of being dropped or at risk of not being renewed for the next 3 years. And we'll talk about non-renewal of provider contracts with payers. We'll talk about the Medicaid state requirement that has affected every single managed care contract today. And if you're not in Medicaid, you can't bill. We'll talk about IPAs and how they come into the rescue with some of the issues we have today. We'll talk about closed panels slightly, and we'll talk about credentialing compliance. It's basically a final step to tell you what you need to do in your practice and how to stay compliant to avoid any liability. And we'll talk about the most frequently asked questions that have been brought up. So the first thing we'll start is the credentialing maintenance. So after you completed the credentialing process, you have your welcome letter, you have your provider ID, and I can say that you're in good condition for the next 3 years. We hope that the insurance company will not bother your facility or your individual doctors for at least 3 years. But it doesn't happen so, because each doctor has a license. Each doctor might move. Each doctor might change something in their demographics, in their file, and that requires maintenance. If we talk about standard credentialing process, most of the doctors have about 10 contracts, 10 insurance companies that they join. Some have more. If we talk about a multi-specialty group, we're talking about 4 or 5 doctors or more. We're talking about a lot of contracting work that needs to be maintained. We need to know when the recredentialing is up due. We need to know if they're setting up EFT. We need to manage all the documents. There has to be a way, a manager, a credentialing specialist, or someone that's in charge of it is doing this, is handling this process, using a software, handling an Excel, somehow writing this down, keeping folders in the office. Automation is the best, of course, but we are not always notified when we are due for recredentialing, but we are notified when our contract is up for cancellation because we did not respond to a notice. So it's important to get all of your doctors and all of your doctors' contracts and all of your facility contracts into one file to know when you're due for recredentialing and to know who are your reps, to know how you're set up, so that that file is maintained, and every time there is an update, you have a trackable system of identifying that you've submitted an update, there's a way to monitor it. It's very important not to miss your recredentialing due dates or to miss your demographic updates. We all know that the federal government, which is the Medicare program, loves to do unannounced site visits. They do it for every single type of provider: a physical therapist, a chiropractor, an occupational therapist, a psychiatrist, a facility of any kind, with exceptions for those that are not eligible to be paid by Medicare. But they provide an announced site visit. If you move location to location or you add locations and they're not in your enrollment file and they stop by that office and you're not there, you will lose your Medicare billing privileges. You will not be able to come back to Medicare for at least 3 years. And the law is changing in November. They will try to maximize it to 10 years. So it's a hassle. It's a problem. You need to have someone, or you yourself who's doing credentialing, to make sure that everything is up to date. So the insurance post-approval maintenance is very important, especially if you're a big physician practice that's constantly recruiting physicians, terminating, hiring new. You need to have a system in place. And I will give you a couple options to those that ask me of different credentialing softwares and what I would recommend. And I will email each one of you separate, and also after the webinar I will follow up. Another aspect of credentialing maintenance is state and federal revalidation requirements. So the two main programs, the Medicaid program and the Medicare program, require revalidation to be performed by individual NPI owners and by type 2 organizational owners. So every single group and every single individual provider that has a Medicare and Medicaid enrollment has to perform a revalidation. Thank God for Medicare, we have PAYCOs, and it's done electronically. And I'm sure that 90% of physicians and facilities today are using PAYCOs. It's not the best, but for revalidation, it's quick, it's secure, it's in time, and usually are done within the first 3 weeks of process. With Medicaid, every state program has a different Medicaid program. Majority of the programs, with exception of Florida, today have an online submissions. So, but those that don't have a paper submission. Paper submissions are tricky. They get lost, they need proof of mail. So state and federal revalidation requirements are very important. If you miss your revalidation date, you need to submit a new initial application. And there is a gap in billing. If you have missed your revalidation date, you have to appeal your effective date so you can back bill for the gap. It's not always a success because insurance, Medicare, for example, would say, well, you missed your revalidation date. We gave you a warning. Well, you have to comply. So I do ask, and as you are listening to this webinar, to know your revalidation dates. It's a public information. There are links on websites that tell you when you are due for revalidation. Your PAYCOS portal will tell you when you are due for revalidation. And they give you almost 90 days from your termination time period to submit your revalidation application. So you do have enough time to submit your validation, but it's important that it's done. Those physicians that are working for groups and feel that they're not responsible to monitor these dates, it's a wrong impression. Since you're an enrolled provider and your group is billing for you for the services and you're getting an employee salary, you're responsible to know your revalidation dates. Your group is responsible to manage them, to make sure they're done on time. Revalidation is affecting a lot of providers today because sometimes the mailing address is not listed on file. It's not the address where the provider is currently existing. They mail out their revalidation request, it's lost, it returns back, and there's no other way to find out that provider's new address. So it's the provider's responsibility to know their own revalidation dates. Whether you keep track in your calendar on your phone or whether it's in Google Calendar, it doesn't matter. Just know your dates. It will help you. Next, credentialing maintenance, that's really important, is the CAQH attestation. CAQH has changed the way we do credentialing. I really feel that CAQH is sort of like a passport for the physicians. It's a passport, like we have a curriculum vitae for the physicians, the resume. CAQH is everything. CAQH is dependent on the way it's kept, the way it's maintained. Whoever is the administrator for the CAQH, whether it's the physician, whether it's the manager, whether it's the credentialing person, it has to reflect the current status of the provider. It has to reflect current information. It has to honestly answer all the questions that are asked in the sanction liability section. It has to have attestation. It has to have uploaded all the certificates. CAQH is a site or a platform that is used by 7 insurance companies, main insurance companies. Some time ago, the state Medicaid program also wanted to use CAQH, but now they were not equipped to do so, so they went back to paper. But CAQH drives your credentialing. If we talk about time frames and delays, it has to do only with CAQH. If everything is updated, if you are tested and nothing is expired, and you passed your attestation, you're good to go. The insurance company can pull the data. And guess what? You know when they pull the data because it's stored in the log. And you get to see, well, Aetna looked at me today, United looked at me today, Anthem looked at me, Cigna looked at me. You're getting a little progress, even though no one is calling you and telling you that there has been a progress in your credentialing. Because insurance companies do not do the follow-ups with you. They only follow up when they need something. But CAQH is the way to go. As long as your profile is updated, you are way on your way to get credentialed under 90 days. And CAQH management has become a lot easier for groups because now we have an administrative portal where you can simultaneously link several doctors and manage them with one user ID. So it's a great, great benefit. So please keep in mind the CAQH attestation is very important, and it's one of the reasons why a lot of credentialing with big payers is delayed, because sometimes it's missing data, it's not attested. I also would like to say some of the insurance companies, for example, United Healthcare, are using attestation method as well inside the Optum login, the healthcare portal link. So it's really important to have the user ID and password for the Optum to see and perform attestation there. And we'll talk about a little bit more on the next slide. So credentialing maintenance, as we mentioned, it's post-contracting, it's existing contracting, and it's demographic updates by payer. So for the past year, everyone started getting faxes from betterdoctor.com. And everybody's thinking, what is it? Is it Yelp? Is it ZocDoc? Or what is it? What is this betterdoctor.com? And betterdoctor.com is a solution for a lot of insurance companies to minimize their costs for calling and verifying. They've sort of created a snapshot from Google and Yelp of the directories. They're able to see where the doctor is practicing, what information is available online, what information is available in the provider directory, and they put it all together in a beautiful letter format, and they fax it into you or mail it to you and say, please confirm. So if you confirm, they'll then process the data, inform the insurance company that you have confirmed, that you're either there or you've changed locations. It's important for you to respond to those requests. I have been to meetings where betterdoctor.com fax was lying in the doctor's garbage can. I told them, what are you doing? Did you respond to it? No, this is marketing. It's not marketing. It's a validation request from several insurance companies that are using betterdoctor.com to validate their data. It's very often that doctors relocate and they do not remove themselves from the groups that used to employ them. And they expect that the group will do it on their own. And the group fails to do so. It's only when the physician is looking for new employment and they need to do new credentialing by adding a tax ID or adding a location, at that point, it's the only time that they actually update their demographics and remove old reassignments. So this is the only time they do it. So insurances, several of them, turn to betterdoctor.com as a search engine to help them analyze the network and to collect the data. So this is what they're doing. So betterdoctor.com, it's either by fax, email. I have not seen anything being mailed because it would be too expensive. So this is something that cannot be ignored. If you get it, please send it to your credentialing person. And if you're a credentialing person, teach your doctors to give it to you or check the mail that it's not missed. Because the insurance company gives a certain amount of days, it's 30 days from the date of that letter, that they have a right to terminate if you don't respond to this fax. So it's an important document, even though it does appear to be like a marketing trick. Next is the calls that physician offices get, so the facility gets, the outsourced vendors for verification. Insurance company outsource a lot of work today. And you may get a call from Jason that will say, hey, I'm calling to verify if you're still at this office. And these are the calls they're making to make sure that the network adequate, the provider directory reflects accuracy. If their call is not answered, they usually try to make 3 attempts. Then they will mail out a letter asking to confirm if the physician is here. They may also fax the same request. If there's no response, you can expect a termination within 60 days from that day from the network. They will terminate. Next thing, what's important, I quite mentioned already before, is terminating reassignment. So anytime you're being hired or you leave the group, make sure that once you leave the group, you terminate the reassignment. You terminate your affiliation with the group. Why we should do it? Because you want to make sure that no one is submitting claims on your behalf. You have no way of controlling it because it's not your tax ID. It's not your mailing address being used. It's your NPI, it's your license. And I think all the physicians work too hard on their license to have somebody else abuse it. So once you leave a physician practice or you leave a place of employment, please don't forget to terminate your reassignments. And this can be done at the time when you start a new employment position. You can terminate and you can add group affiliation as well at the same time. Removing locations to avoid disclosures of cancellation of contracts. Don't forget to update your demographics. It's very important for primary care physicians. Primary care physicians today have a certain time span. They have to dedicate 16 hours to their primary location in order to be called a primary care provider. Otherwise, it's going to be part-time provider and not all the insurances will approve. So removing location is very important. New York, New Jersey, Texas, California, and Florida have a rule for managed care. Specialists can only have a position up to 6 locations in their account. So if you're working for several tax IDs, under your NPI, you can only have 6 locations. It's kind of hard, especially for a specialist, especially for someone who's doing teleradiology, for somebody who's not seeing patients but doing diagnostics. It's very difficult to monitor that. So it's important to know where are your credentials and what locations are on file. So if you have someone that handles this and monitors, you'll be able to track it much easier. If you don't, you'll need to hire someone. Matching billing with existing credentialing. So when we submit claims, we tell insurance company pretty much on the claims what's in your enrollment. When I submit a claim to, let's say, I don't know, to any insurance, United Healthcare, for example, I do indicate the service location where the service was rendered, and I need to make sure that the same location is on file at the insurance company, that there is a match. If there is no match, the claim will get rejected. So it's very important that the physicians are submitting claims for the locations where they see patients, and those locations match the insurance. Not all the insurances ask, all the insurances allow you to submit all the locations, but at least you have to make an attempt. We cannot, physicians have to be liable for the information, for the data that's being provided in the claims. Billers do not have licenses, so billers will never be liable for the information they submit because it's crossed over from the superbill, from the EMR, whatever it was. It's always important to understand that whatever the information is being submitted in a claim has to match the credentialing file on the insurance side. Otherwise, there will be delay in payment. So again, credentialing has to work with billing and vice versa. The next topic we'll cover is the non-renewal of contracts. So New Jersey was hit pretty badly with this, I would say started 6 months ago. They dropped down significantly. Specialists, they dropped down primary care. They have about a physician network right now of about 10% of their providers. A lot of primary care doctors were dropped because they were not reporting HEDIS matters. Some doctors were dropped because they had a shortage in their lives and their roster for the computation on the fee-for-service model. But let's look at the non-renewal of the contract. If I'm a primary care physician, I have patients that I'm seeing actively, and I have a roster monthly, and insurance company sends me a non-renewal letter, it means that they're trying to avoid to take me into the network. They're trying to avoid my extension of contract for the next 3 years. But guess what? They have a right to do that. The insurance company has a right not to renew my contract. And it's in the contract. In the initial credentialing, when we sign, it's written in the contract that the insurance company has the right to not to renew the contract. So this is not something that they hide. It's there, it's available, and they have a right to use it. Now, what do you do when you're a provider? Let's say for 5 years or so, servicing a location, you have certain patients that are coming to you, you have a 70 or 100 patients on your roster, and all of a sudden you're being told, well, dear doctor, we're going to be dropping you, and in 90 days, you will no longer be participating with United Healthcare, and we will inform your patients that they have to go somewhere else. It's a shock. It's a shock. It seems to be something went wrong, and you become angry, you want to appeal it, you want to find out what can be done. So we have a lot of those requests for non-renewal and ways that we want to help you guys get back those contracts. So what are some of your options for non-renewal? Once you get that letter, and it's usually mailed, it's usually never faxed or emailed. It's a letter that's physically mailed to the provider office in big, bold letters, usually very short but straight to the point, telling you that your contract will not be renewed. I would advise you to react right away and to submit your appeal within 5 days of receiving this letter. You have to submit the appeal. It's a letter that you write explaining why should you stay in the network, attaching your roster, attaching your specialty, and explaining in detail why the insurance company should keep your contract in place for the next 3 years. This appeal can be mailed, or what we have done, and it worked, is to hand deliver to the provider representative. So as we all know that we have provider reps that are working at the insurance companies and covering certain regional areas or certain zip codes or certain specialties. They're the go-to people when we have problems. Getting this letter today does not mean that I'm terminated today. Today, I'm still participating, and therefore, I am turning to the provider representative from the insurance company that's terminating, asking them to deliver this letter for a second review. Once they get the letter, so usually we either bring it in or email it or set up a time for the representative to come in to pick it up. They have an internal committee meeting at the insurance, and they review intake of new providers, and they review providers that are being dismissed, and they review appeals. Of course, as a primary care physician, your tool is priceless. You can pull these patients out of this insurance into another insurance as long as they want to stay with your practice. For a specialist, it's a little difficult to do so. So basically, you create a letter stating the facts, giving it to the provider rep, and in 30 days, you will get a response. It will either be a response that we are sorry, we are keeping up with our original decision, or no, we're going to let you stay for an additional 3 years. but you have to respond. Do not give up. I have doctors who just said, I'm giving up. I'm not going to fight this. I'm going to cancel it, and that's it. I'll wait for my termination of the contract. I think that the right thing to do is to use your appeal rights, and you have them. We had cases where we lost the appeal, and we actually had a complaint made to the Department of Insurance. So every state has a department. For example, in New Jersey, it's called Department of Insurance. In New York, it's called Department of Finance. They govern the insurance companies. They are the agency that receives complaints from the healthcare providers with sufficient proof, and then they go to the insurance company and ask them to provide clarity. What happened in this situation? Please explain to us the treatment of this provider, why this provider is not satisfied. And of course, they cannot push the network to get them to stay, but they have to present valid reasons why this provider is being terminated. And this is what the insurance company fights with the Department of Insurance to win their case, and the physician fights to reinstate themselves. But there is a way out. Department of Insurance exists in every state, and they work to accommodate healthcare provider complaints. We worked with them in many cases, and we were successful in many as well. What I've also seen as a trend is getting supporting letters from the patients. So if your practice, an urgent care, primary care, specialty care, received a letter that your contract is non-renewed, and you definitely know that you have a lot of patients with this insurance, you can have the patients write a letter of support. These letters of support can be attached with your appeal. It does help. We have done it for physicians, and it helped them to win their contracts. Next, we will talk about Medicaid state requirements. So the 21st Century Cure Act requires that all Medicaid managed care network providers to be enrolled with a state Medicaid program. This rule impacts every single provider that is treating Medicaid managed care patients. If you are a Medicaid provider and you are seeing Medicaid managed HMO plans, you have to have first Medicaid enrollment. Today, you cannot apply for any Medicaid managed program without having a Medicaid provider ID. Doesn't matter whether you will decide to bill Medicaid. You still need to enroll either non-billing provider or a managed care provider. It doesn't matter what you will do. You need to get a number assigned to you. Your NPI or the facility's NPI has to be in the directory of the state Medicaid program. Every 30 days, every single state Medicaid program exchanges data of the NPIs of the physicians or facilities that are pending enrollment or that are approved already in enrollment, and then the managed care company decides if they will keep the provider contract active or accept the provider that's pending credentialing. It is important that every single physician, non-physicians, every single healthcare provider that expects to see Medicaid managed patients have to first get a Medicaid. Even if you're not planning to get Medicaid patients, you have to be enrolled in Medicaid. It's a crucial rule. It started in 2018. Today, we are near the end of 2019, and we still have doctors and facilities that are pending in their enrollment or have not even filed, and they have the letters already terminating their insurance contracting because they lack Medicaid ID. Please, if you're a large facility, you can filter out. There's a lot of data files that are available today by Medicaid programs in every state where you can plug in the NPI and see if your provider has Medicaid. If the Medicaid pops up, you're good to go. Doesn't matter the provider is new, old. As long as the provider is in the system, the provider ID stays with them for the rest of their lives. So it's to make sure that they have the Medicaid ID. Whether they're an OPRA provider, meaning that they order and refer only, it still qualifies them. They have the provider ID, they're good to go with all the managed care plans. And there's a lot of Medicaid managed care plans. Health First, Affinity, United Healthcare Community Plan, many in different states. So state requirement is mandated that everyone who is applying for Medicaid managed care has to get Medicaid first. So please guys, it's very important to have that done for your doctors, for your facilities, for your providers. And here is the next challenge, the big challenge that everybody's having, and we will have a separate webinar about closed panels and how to fight closed panels. But closed panels, there are pretty much 6 main reasons. Too many providers applying. So every May, medical school releases new graduates. They go through residency, they become physicians. Every May, non-physicians are graduating, PTs or T-speech. Where do they all go? They all want to get into private. They all want to get into the insurances. They want to bill. So eventually, insurance companies reach capacity. When you get a denial because we are closed, because we are full, we have 22 providers in your zip code, or we already have specialists. So these are the 2 main reasons why the decision for closed panel is taking place. There are too many providers applying. There's a network capacity reach. Third one is the insurance renegotiating the contract with the state. So insurance companies often have to, especially Medicaid managed care plans, Affinity, like Health Plus, Health First, they have a responsibility to the state. They have to do reporting. They have to make sure that their contract continues also every year. And if they go into renegotiation with the state temporary, they will close down credentialing. Or they will say that we're not accepting anyone right now. It's not really because they closed panel, because they just closed credentialing. It's just a misinterpretation, but it sometimes happens. We get a call and they say they're closed. No, they're not closed for your specialty. They're closed for everyone temporary. So this periodically does happen. Another thing is the upcoming merger. Anthem bought Health Plus. We had a huge delay in credentialing. We still have delay in credentialing because of this merger, because of the 2 different systems, 2 different teams, 1 insurance company. Credentialing is still done separately. So mergers also lead to closure of panels. Sometimes full-time, sometimes temporary. It depends. So when something is closed temporary, there is a waiting list. You got to get on that waiting list. Not all the insurances are offering, but if you speak to the reps, they might tell you there is a waiting list. Big insurance companies do not have a waiting list, but smaller size do. State restrictions. So state restrictions meaning that either you are not a Medicaid provider yet, and that's why the panel is closed specifically to you as the provider. You got to get into the Medicaid program. So you really have to check that. The battle. So closed panel battle. How do this is just a shortcut or an outline of what you can do today if you are dealing with closed panels. You got to sell yourself. You got to tell the insurance company what is so unique about your services. You open late hours, you open early morning, you have certain equipment on site, you minimize hospitalization. What does your facility do? What is so unique? How do you cut costs for the insurance company? Again, it's marketing. It's the pitch you'll give, the medical necessity you will provide. What does your practice do compared to another practice of the same specialty across the street, not allowing you to get in? So this is something where you actually sit down with your team, with the medical director, and you come up with a plan, and you write pretty much. And we have done this type of analysis for the letter of intent, where we prove to the insurance company that we are different. This is what we do, this is how we do it, and this is how much you will save. So this is something that needs to be done as an appeal, a part of the appeal process for closed panels. Demonstrate the community really needs your services. Physical therapists today are struggling because a lot of panels are closed because there's too many physical therapists. At least to the insurance mind there is. But there is a need. Patients are calling, they're scheduling appointments, there's a post-surgery patients, they need care. So you need to demonstrate in your practice or in your community setting what makes you better as far as the community. English, other language, traveling to home care, doing some kind of other educational fall preventions. You have to make them feel that your services benefits the community, not just an individual. I would also recommend to review the network to identify accuracy of provider directory. So I'll give you a couple cases that we had for cardiology, and I think it was also for urgent care and podiatry, which panels are also closed for many insurance companies. We actually took a Blue Cross directory and started calling every single podiatrist in our zip code that we were applying for. I think it was 10305. We were calling each single provider in that directory and figuring out if they're open. We found 5 that were closed, that they're no longer there, which means the insurance companies are not too careful in updating their directory. It means that those providers are still considered to be active. They have left the practice, never submitted update, and they're taking my spot in that directory. So we did the homework. We proved to insurance company there are not adequate accuracy in the network. Here is the proof. Here's 5 providers who are no longer participating, yet they're in your directory is active. So that's another way of looking and working with the insurance company, trying to prove the closed panel. Keeping up dismissed patient list. So for example, for urgent care, because we do get a lot of walk-in patients, and for any other facility that welcomes walk-in, if you do not accept the insurance, obviously it's either private pay or some kind of pay, but it's not the insurance reimbursement. So we actually advise to create a log of the patient that you had to dismiss because you did not accept their insurance. For primary care, for urgent care, and for some specialties, it works pretty well. So if you create a log and patients just write in their name and the insurance and the ID, this will help you to show the insurance company, here, there is a need. We get people walking into our center and we can't service them because we don't have a contract. And you're saying there's an adequacy in the network. There isn't. Here's the proof of my log. So it's an additional proof that builds up the case for the closure of the panel appeal. And finally, something that everyone does, get to know your local politicians, your local assembly people. Talk to them, get a letter of support, let them come to the office. That helps. That letter of support from the community leader really does help. It shows the insurance company you're not ending here, you're going forward, you want this contract. Another rescue for the closed panels is the IPA. So the IPA is something very familiar. It exists for a long time. It's independent practice associations. It's pretty much they negotiate a contract with the managed care, either fee-for-service or capitation, and you can join them and grab all the plans they offer. Sometimes it's a higher fee schedule, sometimes just the convenience of completing one credentialing application and getting into it. I don't represent any IPA. I work with many of them, but the benefit of it is that you complete one application and you get all the plans. You got to be though careful, because if you want to leave an IPA, you are technically stuck in it for quite a few years. You have to review the agreement. You have to have an attorney that will review it. You have to understand what you're getting into, how much you're paying for the service also. Are they taking a fee from your receivables? What are your requirements to stay in there? So just as a closure for the IPA, yes, they help to get to the panels that are closed, but please look into their contracts, because they literally lock you in. There are some IPAs that lock you in for 3 years. Once you cancel with them, you cannot apply directly for 3 years. So that delegation of contract is stuck with them for that amount of time. And there's nothing you can do. IPA is not an insurance company. The regulations of the Department of Insurance do not apply to them. So you really have to think about your choices and what are you really gaining, what are the advantages you're getting with the IPA before you go in. Credentialing compliance. So this is something very important that has to happen in every single practice. You have to verify your providers. We no longer trust anyone. We have to verify the background. We have to check the OMIG exclusion list. We have to do it not just for the doctors, we have to do it for the professional staff and for every single worker we hire to work in the facility. It doesn't matter if it's a front desk, a clerical, a biller, a credentialing specialist, a physical therapist, a podiatrist, whoever it is. You have to hire and you have to check. You have to check the exclusion list, because if you hire someone who is listed on the exclusion list, you'll be liable and you'll be penalized. And it's a big deal. So OMIG is a state website. It's a government website where every state, every single person, it's a public information, has access to it. After the webinar, if somebody wants to email me and ask you, what is the link, Olga, feel free to do it. I'll give you a lot of them for each different state. But you have to check every single person that works in your team, from physicians, from licensed physicians, from licensed professionals to standard workers of the office. Everyone must go through our OMIG listing. If your manager is on OMIG listing, you'll be paying a great fine, because you cannot employ anyone who is on OMIG listing. That means they have some kind of case, whether it's abuse, whether it's fraud, doesn't matter. They cannot legally work or be hired in a healthcare setting. Next is the National Data Bank Verification. Every single insurance company, when they do credentialing, they run the license of the physician or the Social Security of the physician through a national data bank. It's $4 per report. I suggest that every single physician, every single credentialing person gets this done. Run it through the bank, get the report, you get to know what the sanctions on case, what the malpractice cases, what's going on with the provider. Everything will be there. So this is your credentialing compliance. Maintenance of CAQH, we already discussed. I'm rushing a little bit because we have literally a couple, 10 minutes or so left. So maintenance of CAQH is really important. As I said, this is the key to pushing your credentialing faster. It is the key. Today, it really works well. Tracking documents expiration. So everything expires. Everything is either good for 1 year, some documents are good for 3 years, some things are expiring usually within the first year, such as malpractice, license is good for 3 years, affiliation for 1 year. You have to have a system that will tell you when something is expiring, and it's trackable 30 days before the expiration date. We cannot wait till we get the renewal in the mail. We have to act before. This is important for CQH. It's important for insurances. It's especially important if you're going to credentialing today and your malpractice is expiring next month. It's going to delay the process because they will wait for the letter. They will not push the credentialing through the committee until you get the certificate updated. Monitoring your revalidation dates. Medicare, Medicaid has dates. Medicaid is every 5 years, Medicare is every 3 years. You have to know those dates. It's public information, it's available to you at any time, it's trackable. That's the beautiful thing about it, it's trackable and available. And knowing your contract's renewal dates. Generally speaking, all the credentialing contracts with non-Medicaid or Medicare agencies is 3 years. I have not seen anything longer than that. So usually in 3 years, you'll be coming up for re-credentialing. And this is where you need to resubmit the paperwork. But you're also responsible to do the resubmission of your expired documents throughout the year. So final thoughts from me today. You need to get re-credentialing coverage. You need to get someone who monitors credentialing of your physicians. Forget about the part that you already completed the credentialing. You need someone who will monitor CQH profile, you'll have the revalidation submitted, respond to insurances like betterdoctor.com, do all the attestation. You need to have a person who will create and process this information. We do it for doctors. It's something that needs to be done on a regular basis. And you need to have a program. Finally, I want to say that it's important. We have a couple of things that I'm going to mail out as newsletters. You can keep updates of your credentialing. I'll give you some links also where you can sign up. You need to have a platform. You need to have a credentialing platform that would help you with all the cases, with workflows, with monitoring, expirations, with everything that you need. And I will give you a couple ideas. We are hosting a next webinar for closed panels. We'll send out an invitation. We were asked a couple questions from the webinar and plus the questions that I will directly respond. So questions that I pulled that were I think were asked because of the doctors kind of not knowing where we stand with credentialing. How long does it take to complete the credentialing process? So for the new provider, it's 90 days. For established providers that are making changes, you're looking within 60 days. We have done it under 30 days. It all depends on the CAQH, it depends on the documents, it depends how the application was completed, and on the follow-ups you do. So it really depends how you prepare that application that goes out. For facility enrollment, for urgent care, there is a periodic site visit. For diagnostic facilities, it does take a little bit longer, so it's about 180 days, also depending on the payer. And also, let me tell you, when they're behind, push them. Write a letter, seek the medical director, seek their supervisor. Let them know that you're concerned because every day you're not contracted, you're not billing, you're not seeing patients, you're losing money. So it's really important to keep track of your credentialing processes. Question asked by a doctor, can I begin seeing patients without completing the credentialing process with the insurance company? My answer would be no, because you really have to look at the patient's plan. If the patient plans allows out of network, please do get a deductible and see the patient. But if there is no such thing, if it's an HMO plan, you got to get credentialed. You have to get credentialed and then see the patient and bill. The only trick today is the Medicaid allows you to backdate your credentialing. It's applicable in every single state, so you can backdate it to the first time you saw the patient. So you get approved, and then you send a letter of appeal with the proof of the claim, and then you can backdate to the effective date you first saw the patient. Medicare rule is 30 days. So you submit an application, you have 30 days maximum you can go back. So somewhere, at least with those two, you have a room where you can see patients. But with everything else, it's the future effective date. You get credentialed, you get an effective date, that's the date where you officially can start seeing patients. Do you recommend joining IPA or see contracts directly? I kind of explained it already that if you're stuck with closed panels, you lost your appeal, IPA is the way to go, but I would recommend definitely looking at your contract, speaking with your attorney, and look at the advantages and risks. If I have pending malpractice cases, should I disclose to the insurance? Yes. We have to be transparent. National Data Bank doesn't ask for disclosure. National Data Bank gets this information from insurance company, the medical insurance company, the errors in admission, the professional malpractice. So this information is already in their hands. If we are not disclosing this to the insurance company can cancel the credentialing process and say, guys, you're not being honest with us. We have a case here from National Data Bank. And this is what quite often happens, especially to specialists, neurologists, cardiologists, radiologists that are dealing with a lot of these cases. Whatever is pending, whatever is settled, everything has to be disclosed. Those questions have to be answered in the proper manner. Otherwise, you will not be able to credential. And if they put a bar because you mispresented the information, the bar can stay up to 3 years. So it's really important to outlay all the pending cases and explain your sanctions if you have any. But National Data Bank will have this information on the provider as well. So we as a company, we are between the provider and the insurance. This is what we do. We have a couple solutions for credentialing platform, couple solutions for provider maintenance. I will be holding a next webinar in December, and everyone who participated today will get an answer to their questions. I'm preparing to start this tomorrow. So I thank everyone for joining me today. Have a wonderful Tuesday evening and a wonderful day. Bye-bye, everybody.